Welcome to Stanford Medcast, the podcast from Stanford CME that brings you the latest insights from the world's leading physicians and scientists. If you're joining us for the first time, be sure to subscribe on Apple Podcast, Amazon Music, Spotify, or YouTube to stay updated with our newest episodes. I am your host, Dr. Ruth Adibuya. In this episode, I will be chatting with Dr. Juliet Knowles. Dr. Knowles is an assistant professor of neurology and neurological sciences and of pediatrics at Stanford University. She is a physician scientist specializing in pediatric epilepsy, providing clinical care and leading a research team focused on basic, translational, and clinical research. Dr. Knowles completed her MD and PhD in neurosciences at Stanford University, followed by a residency training in pediatrics and child neurology at Stanford, where she also served as chief resident. She further pursued a clinical fellowship in pediatric epilepsy and postdoctoral research on myelin plasticity and epilepsy under the mentorship of Drs. Michelle Monge and John Huguenard. Dr. Knowles has received several honors, including the Stroop Award for Rising Star in Epilepsy from Johns Hopkins University in 2021 and the Alterman Research Award from the Pediatric Epilepsy Research Foundation in 2020. She serves on the Scientific Program Committee of the American Epilepsy Society and the Research Committee of the Child Neurology Society. Thank you so much for being here with me today.
Thank you so much for having me, Ruth. It's a real privilege to be here.
I'm really excited to have this conversation with you about epilepsy, especially pediatric epilepsy. It's a topic that sparks a lot of discussion, and it's a privilege to hear from an expert like you. When most people think of epilepsy, they often picture dramatic seizures with uncontrollable muscle contractions. While that is one form, epilepsy is actually a broad condition with many different types of seizures and presentations. Can you start by defining what epilepsy and seizures are, and then could you expand on the different types of seizures and walk us through the key criteria for diagnosing epilepsy?
It's helpful to first start with some definitions and to distinguish between seizures and epilepsy. Seizures are transient events. In general, seizures are defined in terms of their brain activity component, which we can visualize with an EEG, and this involves abnormally synchronous or excessive activity. Then there's also the outward manifestation of the seizures, what we call the seizure semiology. And as you had mentioned, this can involve tonic-clonic shaking of all four extremities, a dramatic presentation, which we would call a generalized tonic-clonic seizure. But there can be much more subtle seizure semiologies, such as the brief behavioral arrest that occurs in absence seizures. We conceptualize seizures in two basic categories, focal and generalized. Focal seizures are those that begin in one region and one hemisphere of the brain, whereas generalized seizures are those that begin in both sides of the brain at once. These two types of seizures have different causes, and they also have different treatments. Just as there are two different seizure types, there are different epilepsy types. But first, let's define what is epilepsy. What the diagnosis of epilepsy means is that the person's brain has an enduring predisposition or tendency to have unprovoked seizures if left untreated. And the diagnosis can be made under a few different conditions. One, if someone has two unprovoked seizures, generally 24 hours or more apart, then that is often considered to be sufficient for the diagnosis of epilepsy. Or the person might have a single seizure with a greater than 60% of having another seizure. In many cases, that would also be sufficient. Finally, there are epilepsy syndromes where recurrent seizures go together with certain patterns of activity on the EEG and at certain ages. When we see those factors co-occur, that is also sufficient to make the diagnosis of epilepsy. The type of epilepsy that someone has is determined by the type of seizures that they have. For example, there are focal epilepsies, which involve focal seizures only, generalized epilepsies that involve generalized seizures only, and mixed forms of epilepsy involving a mix of generalized and focal seizures. In some cases, the diagnosis of epilepsy is made, but we don't know where the seizures begin. So we just say onset unknown.
That's a really helpful distinction between seizures and epilepsy, especially in terms of understanding the brain activity component versus the outward manifestations. The way you broke down focal versus generalized seizures and how they not only present differently, but also have different causes and treatments really underscores the complexity of epilepsy as a condition. I appreciated your comment that an epilepsy diagnosis isn't just about the number of seizures, but also factors like risk prediction and EEG patterns that can point to specific epilepsy syndromes. Given that complexity, I imagine early detection is crucial. That brings me to imaging. Are there any early warning signs in imaging that could allow clinicians to intervene before seizures worsen?
Brain MRI and EEG are standard tools in the diagnostic investigation of seizures and epilepsy. They play an important part both in diagnosing the epilepsy and its cause and guiding treatment. It's particularly important to get a brain MRI when the epilepsy involves focal seizures. That suggests that there may be a focal structural area of abnormality that's causing the epilepsy to occur. When we obtain the brain MRI, we sometimes do find actionable structural changes that would influence our approach to treating the epilepsy. Some examples that would immediately influence our treatment might include multiple benign hamartomas in the brain that occur in a condition called tuberous sclerosis. That might influence the type of epilepsy treatment, including medications that we give. Sometimes seizures can come from a focal cortical dysplasia, which is just a small, limited area of disrupted development, but that can lead to rapid onset and severe forms of epilepsy. A common finding is hippocampal sclerosis in the case of temporal lobe epilepsy, which is the most common type of epilepsy. These findings might influence our choice of medication for the seizures, or they might encourage us to consider surgery earlier in the course of treatment.
I think that's really compelling, especially how imaging doesn't just confirm an epilepsy diagnosis, but can actually shape treatment strategies from the start. It makes me think about the importance of timing in epilepsy care. If an MRI reveals a structural abnormality early enough, it could open the door for more targeted interventions before seizures become more difficult to manage. And I think that question of timing is even more critical when we look at neonatal epilepsy. What challenges do neonatal epilepsies present, and how do they differ from epilepsy that develops later in childhood?
Neonatal seizures and epilepsy often occur in the setting of acute, significant issues that arise in the perinatal period. Those things need to be addressed immediately. Some examples include perinatal hypoxic ischemic encephalopathy, the condition resulting from lack of adequate oxygen during the perinatal period. Brain hemorrhages or ischemic strokes can occur in infants. Sepsis, meningitis, encephalitis, so infectious causes. Then genetic metabolic etiologies tend to present in the neonatal period. So many types of genetic epilepsy as well tend to manifest during this time of life. This list of causes requires us to take action immediately to address those problems. So you're right. When a neonate has a seizure, it's an emergency, and we aggressively investigate that with EEG and MRI.
You've highlighted how neonatal seizures often stem from acute medical events that require immediate attention. With that in mind, how do the causes, diagnostic approaches, and treatment strategies differ when managing epilepsy in neonates versus epilepsy that develops later in childhood?
The same categories still apply in childhood, sort of structural changes in the brain, including acquired structural changes like brain injuries or congenital malformations of the brain, as well as infection. But the likelihood of causes shifts as you think about older children. For example, some epilepsy syndromes, such as childhood absence epilepsy, which is something that we study in my lab, tends to present in middle childhood between ages 4 and 8. We think about these causes a bit differently in older children.
The challenges of neonatal epilepsy really highlight the need to understand the broader mechanisms driving epilepsy progression. As you mentioned, while the underlying causes might shift with age, there's still a continuum of factors influencing how epilepsy develops over time. One area that plays a key role in that progression is myelination. Your research specifically explores how maladaptive myelination contributes to epilepsy. Could you explain what maladaptive myelination is and why it plays such a critical role in epilepsy?
It's important to provide some context for the work that we did on maladaptive myelination. This work began when I was a resident in neurology here at Stanford. Around that time, the lab of Michel Mange published a really important study in which they used a tool called optogenetics to demonstrate that recurrent patterns of neuronal activity in the brain can influence structural changes in myelin in the same circuits that are having this recurrent activity. This was a paradigm shift because prior to that, our understanding of brain myelination is that it occurs early in life as our brains are forming, and in a stereotyped progression. We understood that myelin was fixed or inert as the brain adapted. What the study from Dr. Mange's lab demonstrated was that this is not the case. Actually, even after this process of developmental myelination is complete, recurrent patterns of neuronal activity can, in fact, alter myelin structure in a circuit-specific manner. Moreover, those myelin changes subsequently influence the activity of that brain circuit. It's a form of brain plasticity and adaptation analogous to synaptic plasticity. Where did my work come in? I remember learning about this discovery, which they called adaptive myelination. At that time, I was thinking a lot about pediatric epilepsy as I took care of children with seizures that had these recurrent patterns of unhealthy behavior in the form of seizures. This prompted me to wonder whether recurrent patterns of unhelpful brain activity could also influence myelin structure. If that were the case, what impact might that unhealthy myelin plasticity have on the brain subsequently? To study that question, I did a postdoctoral fellowship with Michelle and Dr. John Huguenard, who is an epilepsy researcher and expert here at Stanford. We looked in mouse and rat models of generalized epilepsy. And what we found is that seizures induced myelin structural change. We found thicker myelin sheaths and increased numbers of myelinated axons in the seizure network of these animals. We then did further experiments where we genetically engineered mice so that we could block myelin plasticity during this period of seizures. What we found is that mice that have seizures and normal myelin plasticity have a progressive course where the seizures become more and more frequent over time. And this is reminiscent of children with severe forms of epilepsy, especially generalized epilepsy, that have this progressive course. By contrast, in the same type of mouse, when we blocked the activity-dependent myelination during the period of seizure progression, we found that the seizures did not progress to nearly the same degree. They persisted at a very low level. What this information indicated to us is that seizures are, in fact, inducing myelination in an activity-dependent manner. This seizure-induced myelination, in turn, reinforces the same seizure pattern and makes it easier for the brain to have seizures. We termed this phenomenon of seizure-induced myelination that reinforces seizures maladaptive myelination, to contrast it from the adaptive myelination that was described by Michel's group earlier, in which patterns of activity that underlie learning induce myelination that helps retune the network to that same pattern of sort of helpful activity.
That's really exciting, thinking about epilepsy not just as a disorder of neurons, but as a condition influenced by this broader ecosystem of neuron-glial interactions. It opens up so many new possibilities for intervention, especially if we can target these supporting cells to disrupt the cycle of seizure.
You hit the nail on the head. These glial supporting cells, like oligodendroglial cells and astrocytes, are part of this complex ecosystem in the brain, and they play an underappreciated role in sculpting brain network activity. That is a new frontier that we're just beginning to understand the role of neuron-glial interactions in health and diseases like epilepsy.
That brings me to your 2022 study on generalized epilepsy progression. In that study, you discussed how myelin changes may worsen seizures. What does this mean for developing treatments that address both seizures and their underlying causes?
That is an open question that my independent research lab started about 3 years ago is working on. One lead that we stumbled on in the course of our earlier work is that We wanted to pharmacologically block myelin plasticity during the seizures in complementary studies to the genetic blockade that I told you about a few minutes ago. In the same mice that have the progressive generalized seizures, we treated them with a drug that is a histone deacetylase inhibitor. This drug prevents epigenetic changes that are required for oligodendroglial cells to mature so that they can form myelin sheath. The type of HDAC inhibitor that we used for our study in mice is not a drug that we could likely use in children because of its toxicity profile, but there are other FDA-approved HDAC inhibitors, including one called phenylbutyrate that's already being studied for children with epilepsy. That's one interesting lead. But we still have a lot more work to do to understand the molecular and cellular mechanisms that are going on in neurons and oligodendroglia during this process of maladaptive myelination. That's something that my lab is working on now, is identifying those specific pathways that get activated in oligodendroglia during maladaptive myelination. And a key aspect of this work is trying to identify mechanisms that are relatively specific to maladaptive myelination in seizures compared to adaptive myelination during learning. Because we're talking about treating children, we don't want to give a drug that would impair healthy plasticity that's needed for learning.
That's such a critical balance, finding ways to disrupt maladaptive myelination without interfering with the healthy plasticity that's essential for learning and development. It's really exciting that your work is not just identifying potential drug targets, but also thinking about how to refine treatments so that they can be both effective and safe for children. That also makes me wonder about myelin plasticity more broadly, though, especially how it might change across different age groups. How does myelin plasticity differ in children compared to adults, and why is this difference important for understanding pediatric epilepsy?
Animal studies have shown us that the brain has this capacity for neuron activity regulated myelin plasticity well after the initial developmental myelination of the brain is complete. However, that capacity does decline with older age. The capacity for myelin plasticity peaks when we're young. What that means for us when we think about children with seizures and epilepsy is that their brains are susceptible to heightened plasticity that may result from either healthy adaptive patterns of neuronal activity or maladaptive patterns of neuronal activity like seizures.
That is a compelling insight since myelin plasticity is at its peak in childhood. Both healthy and maladaptive patterns of brain activity can have an outsized impact, and it really underscores what you mentioned earlier, that early intervention is so important, not just to stop seizures, but to potentially reshape how these neuronal networks develop over time. With that in mind, your work suggests that myelin plasticity could be a novel therapeutic target. What potential treatments or therapies are on the horizon based on your findings?
I mentioned the HDAC inhibitor that's being studied in kids, phenylbutyrate. That's still in clinical trials. My lab is actively investigating targeting specific pathways that we know get activated during maladaptive myelination. We don't as yet have a specific compound that we're ready to send to a clinical trial yet, but I think that will come eventually. One really exciting direction for pediatric epilepsy care is neuromodulation. This is a category of treatments that includes vagus nerve stimulation, where peripheral repeatedly provides stimulation to the vagus nerve that then transmits that information to the brainstem and then the rest of the brain. Other forms of neurostimulation include deep brain stimulators that are implanted in the deep nuclei of the brain and that are very interconnected with other parts of the brain, as well as more focal stimulators such as responsive neural stimulators. An open question is whether these types of treatments that introduce new patterns of neuronal activity into the brain can reverse maladaptive myelination that has already occurred.
Since these approaches are already being explored in clinical trials, how close are these therapies, both neuromodulation and pharmacological interventions, to actual deployment in practice?
In the case of phenylbutyrate, we're already in clinical trials. In the case of the neuromodulation techniques that I mentioned, VNS is already widely used in children with refractory epilepsy. DBS and RNS, the two other approaches, are approved relatively recently for use in adults and beginning to be used in children. This is an exciting time to understand how to optimize those approaches to help kids with refractory forms of epilepsy. In terms of the other directions, we're still in the really basic preclinical stages of understanding mechanisms and how to target them. That's a bit further out, but we're persistent.
It's encouraging to hear that some of these approaches are already making a difference in children with refractory epilepsy, and that the others like DBS and RNS are starting to bridge the gap from adult to pediatric care. As you mentioned, even though some of the molecular targeted therapies are still in the early stages, it sounds like the progress in this field is really promising. That brings me to a question about the connection between research and patient care. How do you integrate the findings from your research into your everyday experiences in the clinic with patients?
I'm fortunate in that my work as a clinician is really synergistic with what we do in the lab. Working with kids that are affected by epilepsy and their families is the inspiration for the hard work that we do in the lab. It's my why. It keeps me going in the lab no matter what hurdles we face. There is a lot of overlap in what we do in the lab and what I do in the clinic. My lab has two main focus areas. We're interested, first of all, in understanding what leads to and what perpetuates severe forms of epilepsy. One example of that is the maladaptive myelination mechanism that we discovered. Then the other focus area is that we study different forms of genetic epilepsy with a specific goal of developing precision treatments that address the genetic cause of the epilepsy. This work is intertwined with what we do in clinic. I spend a good deal of my time working in our genetic epilepsy clinic, where pediatric epileptologists like me work alongside a genetic counselor and a neurogenomics specialist to identify genetic causes for epilepsy. And genetic diagnosis can really be a game changer. It can open up new opportunities for a child and their family, like the opportunity to try a precision therapy if one is available or participate in a clinical trial. It can help us to connect the family with support systems. Sometimes there are foundations for specific genetic disorders. And it can also mark the end of what we call the diagnostic odyssey, where we're doing lots of testing to try to understand what's causing the epilepsy. It can also help us predict the future and help the family plan for what lies ahead for their child.
I loved hearing about the synergy between your research and clinical work. Your unique perspective as both a scientist and a clinician allows you to play such an important role in advancing epilepsy research and care. It's truly inspiring to see how your work not only helps uncover mechanisms in the lab, but also provides real solutions for families navigating epilepsy. Looking ahead, with all the advances happening in epilepsy research, what are the most exciting breakthroughs that you foresee in pediatric epilepsy over the next 5 to 10 years?
We're in a new genomic era of epilepsy. We are increasingly able to obtain genetic testing and to identify a change in a single gene as a cause of epilepsy. The diagnosis of a specific genetic cause for the epilepsy opens up new lines of investigation as to whether we can treat that epilepsy with a precision therapy that targets the underlying root genetic cause. Some of the existing precision therapies for these genetic forms of epilepsy include already FDA-approved drugs or gene-based approaches like antisense oligonucleotides or gene therapy. These are precision therapies, and some of them may turn out to be cures. We are in a period of revolution. Many of these precision treatments are still in preclinical stages or just beginning to be tested in clinical trials. We're just at the beginning of this, but it's a really exciting time to be practicing pediatric epilepsy.
It truly sounds like we are at the forefront of a major shift in epilepsy care. The idea that we're moving beyond just managing seizures to potentially curing certain forms of epilepsy through precision therapies is groundbreaking. And even though many of these treatments are still in early stages, the fact that we are in a genomic era where targeting the root genetic cause is becoming a real possibility is incredibly exciting to hear. I know we could keep this conversation going for a long time because there's so much more to explore, but what really stands out to me from our discussion is the complexity and diversity of epilepsy, especially in children, and how research in myelin plasticity is opening up entirely new avenues for treatment. I've also been so inspired by how your work isn't just pushing the boundaries of scientific discovery, but also shaping the future of how we care for patients. The breakthroughs that you mentioned happening in pediatric epilepsy give us so much to anticipate, and I really appreciate you sharing your expertise and your insights with us today. Thank you for helping us understand not just where the field is now, but where it's headed and what it means for patients and families.
Thank you, Ruth. It was a pleasure to talk to you.
This episode was brought to you by Stanford CME. To claim CME for listening to this episode, click on the Claim CME link below or visit medcast.stanford.edu. Check back for new episodes by subscribing to Stanford Medcast wherever you listen to podcasts.